My topic is on review and reconciliation of medicine in geriatric patient and unmet need. So our learning objectives are understand the key issues geriatric pharmacotherapy and understand the effect of aging on pharmacokinetics and dynamics, understand the principles of drug prescribing for older people, and discuss risk factor for adverse drug events and way to mitigate them. So geriatric patients are prone to adverse drug events, we all know, due to multiple morbidity and polypharmacy. Age-related pharmacokinetic and pharmacodynamic changes also increase its risk. Medication review and reconciliations aim to ensure effective pharmacotherapy, and despite available tools or guidelines, this remain an unmet clinical need in many settings. Why is this important? Because there are high prevalence of potentially inappropriate medicines, increased risk of hospitalization, falls, cognitive decline, and drug-drug and drug disease interaction. There are also care transitions. Care transitions mean transition of care-related problem. There are during admission, during the discharge or transfer. There are some during the transition from that that time. There are different kind of problems are and their vulnerable point of medication. There are some medication error can be often occurs. Regular review improves patient safety and optimize therapeutic outcomes. So there are challenges of geriatric pharmacotherapy because different new drugs available each year, FDA approved off-label indications, and they are expanding, changing managed care formularies, advanced understanding of drug-drug interactions, increase popularity of nutraceuticals, multiple comorbid state, polypharmacy, I have already mentioned. Medications compliance is a big issue, and effects of is aging on physiology, and also pharmacotherapy and pharmacokinetics and dynamics on drug therapy, and also cost of the medicines. So why is special with the elderly? Because high prevalence of chronic multiple, that is the same thing. And there are different tools and guidelines like Beer's criteria there. They identify drug to avoid or use with cautions in older adult. And stop guidelines means screening tool of older person's prescription. That is how when they should be stopped. Highlight potentially inappropriate prescriptions. And start tools are the screening tool to alert to right treatment. Stop means to stop that medicines, and start means when we should start that medicine. If it is missing, identify necessary medication that may be missing. And also medication appropriateness index are there. They provide structured evaluation of each drug's appropriateness. I give one example, simple example. A patient of 78-year-old female with hypertension, diabetes, osteoarthritis, and depression. She was on following medicines. Simply, the name of the medicines are amlodipine for hypertension, metformin for diabetes, and for osteoarthritis, she is given NSAID, ibuprofen, and for depression, she is given amitriptyline. When reviewing and reconciliation, we have found that in Beer's, according to Beer's criteria, amitriptyline should be avoided due to anticholinergic effect, and it may raise the confusion, increase the level of confusions and falls. A stop criteria said NSAID in hypertension increase risk of renal impairment and elevated BP also. And start criteria said that no calcium or vitamin D supplementations given despite osteoarthritis. That should be considered adding. So action plan here should be prescribe amitriptyline, review NSAID use, initiate calcium, vitamin D, and also pharmacological pain management in other way, and bone health measures. Most common medication associated with adverse drug reaction in the elderly are, we know, opioid, NSAID, anticholinergic, benzodiazepam, and also cardiovascular agents, CNS agent, and musculoskeletal agent. And according to Beer's criteria, there are high potential for severe AD, adverse drug reactions. like amitriptyline, digoxin, and high potential for less severe ADR antihistamines like this. These are the charts. And next, we should know about little bit about the prescribing cascade. In elderly people, because of multiple comorbidity, they are given and multiple symptoms, one drug can be given, and due to this side effect or adverse event, we may think that it is a new disease, and we prescribe another medicine for to combat that side effect. So AD is misdiagnosed as adverse drug reaction or event is misdiagnosed as a disease, and another drug is given. If we if there will be the possibility of alternating that medicine, first medicine, so no second medicine should be given for that adverse drug reaction. In that way, prescribing cascade occur in mainly with polypharmacy in elderly people. And there are the drug-drug interactions. It may lead to adverse drug event. So most common drug-drug interaction with cardiovascular drug, psychotropic drug. Most common drug interactions effects are confusion, cognitive impairment, hypotension, acute renal failure. And why there are drug-drug interactions? Maybe due to absorptions, maybe increase or decrease, or additive effect, or opposite effect, or metabolized by inhibitor or inducer. We all know. And common drug-drug interactions are there. I'm not mentioning this. Also, drug-disease interaction. Obesity altered the volume of distribution of lipophilic drugs. So we should consider the dose. In that case, we should particularly reconsider that particular amount of drugs. And ascites also, the volume of distribution of hydrophilic drugs. In case of ascites, it alters. Renal hepatic impairment may impair the metabolism and excretion of the drug. Toxicity may occur, and drug may exacerbate medical conditions. And these are the common drug disease interactions. First one is the NSAID plus congestive heart failure or heart failure. If we give thiazolidine and plus congestive heart failure, it may cause fluid retention and exacerbation of the heart failure, like this. So, and there are also one thing very interesting, and we should consider it very minutely, the anticholinergic burden scale. Why? What is the idea? The idea is to reduce the cognitive impairment of elderly by using this anticholinergic burden scale. If the sum of the score is 3 or more, then medications with lower score, if applicable, should be considered. So these are the scale. There are some online app are there where we find that anticholinergic burden scale of different drugs. So like ACB score of alprazolam is 1, and anticholinergic burden of some drug like meperidine, it's 2, and anticholinergic burden amitriptyline is 3. Amitriptyline is 3, and also flavoxate, hydroxyzine, these are 3. Means there are more chance of anticholinergic side effect like fall, dementias are chances are much more. So if lesser anticholinergic burden scale alternative drug can be given, so the chance of fall will be diminished. So we should consider or calculate the anticholinergic burden in case of especially elderly population. So these are the tools we all know, and these are there are stop criteria and start criteria. And stop criteria screening tool for older people, and these are the according to the system they have written that tool, that drug, the digoxin at low dose, when should be given, when should be stopped. These are the in start, and in case of start screening tool, it is also mentioned. So clinical pharmacologists can help identify ways to reduce the polypharmacy in elderly people, reduce the use of potentially inappropriate medication in elderly adult, avoid drug disease interactions, adjust doses for renal hepatic impairment, avoid therapeutic duplications, avoid prescribing cascade, better replacing with suitable alternative if possible. Also enhancing medication adherence by simplify the regimen, utilize the pill organizer or drug calendars, advise periodic round back checkups, educate older adults on how to safely and effectively take the medications. They should maintain an accurate list of all medication that a patient is currently used, and the list should include the drug name, dose, frequency, route, indication. And patients should be made aware of potential drug confusion like sound alike, look alike, like drugs. So this is my last slide. So medication review and reconciliation are essential yet underutilized in geriatric care. Structures, tools, and guidelines help identify the risks and optimize therapy. Addressing system gaps and promoting team-based approach can significantly enhance medication safety and quality of uh, life for older adult. Thank you.
Thank you, ma'am. Thank you for the.
I want to share one thing. I am from Arjikot Medical College. So we have one clinical pharmacology OPD, 2 days, Tuesday and Friday. In that OPD, polypharmacy patients are come. Patients are like they are referred. They are super specialty department. So when they are given more than 5 drugs, of the patients are visiting different more than 3 different clinical OPDs, or they have any drug interactions or adverse event, they're coming. So most of the patients are mainly geriatric patients. So we are running this OPD 3 years, and we are very much like satisfied by with this knowledge. We are trying to improve in a little way in the government setup. That clinical pharmacology OPD, that is, we are doing medication reconciliation. Thank you, ma'am.